So this week we have a 55-year-old man with no significant past medical history. He comes in with dizziness for the past several months, and he describes it as feeling like he's about to pass out. It's usually when he's standing. He's never had any loss of consciousness, no other prodromal symptoms, and he takes no medications. So on exam, his vitals at triage are normal. Here are his orthostatic vitals. The rest of his exam and his EKG are unremarkable. So based on this information, what would be the next best step? Would we check basic blood work, ask the patient to stand for longer and repeat his blood pressure, order a Zio patch, or order an echo? Take a few moments. So the answer for this is going to be B. We should have the patient stand for longer and repeat his blood pressure. Let's go over why. So first, we're going to review the definition of orthostatic hypotension. It's when someone has a drop in their either their systolic blood pressure of 20 or more, or their diastolic blood pressure of 10 or more with standing. While we typically think about this significant drop in one's blood pressure happening pretty soon after standing up, it's important to recognize there is a subgroup of patients who have symptoms from OH, but their blood pressures may not drop until they've been standing for a prolonged period of time, for at least 3 minutes. And this is what's known as delayed OH, as opposed to the classic type of orthostatic hypotension. And when we're considering what's causing our patients' orthostatic hypotension, this is a framework that we can use. Most commonly are causes where the patient has either lost a significant amount of intravascular volume, or they're on certain medications like antihypertensives that's causing the OH. I'm not going to go in depth about all of the different meds that can do this, but just be sure that whenever you're suspecting orthostatic hypotension, to do a thorough review of your patient's med list. Next are your disorders where the autonomic nervous system is failing to cause enough vasoconstriction after standing up. And this can be either from a primary neurodegenerative disorder like Parkinson's, or secondary autonomic neuropathy from something like poorly controlled diabetes. So this brings us to our study that I want to go over. This came out in 2006. These authors looked at 230 patients who were referred for autonomic testing with a tilt table test. And of these 330 patients, 108 of them were diagnosed with OH. But when they broke down this group even further, they saw that more than half of them, 54%, didn't experience any significant BP drop until after 3 minutes of standing. And of those with this delayed OH, many didn't get orthostatic until after 10 minutes of standing. And so these these authors argued that delayed OH is an underdiagnosed phenomenon that warrants more attention, and it's definitely something that we can easily miss if we don't check for it, if we don't have our patients stand for long enough. And not only are we likely underdiagnosing delayed OH, but patients who have this may be at risk for poor outcomes in the future. So these authors took the same cohort of patients and followed them for 10 years. And they found that many of the patients who initially had delayed OH had now progressed within these 10 years to the classic type. And then of those who progressed, many now carried diagnoses that implicated a neurogenic cause of primary autonomic failure. So a lot of these synucleinopathies like Parkinson's, dementia with Lewy bodies, multiple system atrophy, and even pure autonomic failure. And so from this 10-year follow-up, they concluded that the finding of delayed OH in many patients is kind of like a canary in the coal mine for later progressive autonomic failure. So to summarize, after we've checked orthostatic vitals, if they're still normal, but you still have high clinical suspicion for OH, you should have your patient remain standing for at least 3 minutes and then check the standing blood pressure again. This way you can check for delayed orthostatic hypotension. And then lastly, if you do diagnose your patient with this, keep a close eye on it over time, because it could be a sign of early autonomic failure as part of an underlying synucleinopathy like Parkinson's. Any questions?
Oh, I have a question. You said there were almost 40% of folks that we missed who developed this after 10 minutes of standing. So would we still be missing a significant portion of patients with only the 3-minute interval?
Yeah, potentially. How I usually go about it is if I have a patient who is endorsing symptoms that sound a lot like orthostasis, and their blood pressures don't drop even after 3 minutes, yeah, I might have them stand for longer. If they have if they're on medications that could be obvious causes of it, you might think just to remove those first, if their comorbidities allow for that, or if they're clearly volume down, you can treat that first and then just see if they're symptomatic still. But if you don't really have any other good cause for it and they're still having symptoms, then yeah, I think there's definitely reason to have them stand for longer as long as they tolerate it, and then repeat the blood pressure.
Okay, thank you.
Yeah, no problem. Any other questions? All right. Thanks, everyone.